Thank you guys for having me. Thank you guys for having me today. As Chantry mentioned, my name's Catessa. I'm our lead antimicrobial stewardship pharmacist at WVU Medicine. And today I will be talking about combination antibiotic therapy, Two's Company. A brief objective for today will recognize indications for which combination antimicrobial therapy may be appropriate. If you guys have questions during this, as Chantry said, please feel free to unmute and ask or put them in the chat, and I will get to them as soon as I can. All right, so I first wanted to start with combination therapy definitions. So when we talk about combination antibiotics, a few different terms are often thrown around. You may hear the term synergy, you may hear the term double coverage or dual therapy, and then you may hear adjunctive therapy. So going into each one of these and what exactly that means. So synergy is when we combine two agents for enhanced activity. So off we're combining two agents that have different mechanisms of action for enhanced activity against the pathogen we're trying to treat. And usually with synergy, one of the antibiotics is not active against that pathogen on its own. So I'll get to an example of this in a moment that really explains that and an example for all of these. The second is dual coverage or dual therapy. Once again, we're using two agents with a different mechanism of action to target the same bacterial pathogen. But in this case, both of the agents are fully active against the pathogen by themselves. So often you could use either of the agents for monotherapy, or you may be using them together to target different mechanisms of action, but they would work on their own as well. And then another term you may hear is adjunctive therapy. So this is an addition of a agent for specific antibacterial properties. Let me go through some examples of each of these to really help hammer home the points. So synergy, the best example you can think of with synergy is when we use a beta-lactam and an aminoglycoside together for gram-positive endocarditis. This has fallen out of favor a bit, especially for enterococcal endocarditis. But the thought process behind here is that you use the beta-lactam to open up the bacteria, it binds to the cell wall, and you have killing of the bacteria. But then you also allow the aminoglycoside to go in to the gram-positive pathogen and bind to the proteins and then also get complete killing. So the aminoglycoside on its own would not have reliable activity against the gram-positive pathogen because it couldn't get through to get to the binding site. But with the addition of the beta-lactam, you can. So that's what they're synergistically working together, whereas the aminoglycoside would not work on its own against a gram-positive pathogen. What we also hear is double coverage dual therapy. Some great examples of this are dual antibiotic therapy for Staph aureus bacteremia. If you have been on a few of our presentations in the past, you've heard of many cases for this. So that's often when we're using two active agents for Staph aureus bacteremia. So thinking MRSA, something like daptomycin and ceftaroline. Both of those have complete anti-MRSA properties and killing on their own, but we're using them together. Another example of this would be empiric double coverage of gram-negative pathogens. That would be if you're targeting Pseudomonas with a beta-lactam and a fluoroquinolone or an aminoglycoside up front before susceptibilities are known. And then often we use dual therapy for uncommon gram-negative pathogens. So think Stenotrophomonas multifida infections. And I'm going to dive into that one a bit more. But same kind of concept using two antibiotics that have complete activity against the bacteria. And then adjunctive therapy is when we're adding antibiotics for specific antibacterial properties. So not so much not so much for the coverage that it has, but for these specific properties. So often we will talk about the addition of rifampin to anti-staphylococcal antibiotics for biofilm penetration. And I won't give too much away for that because I think we have a case on that. And then also the addition of linezolid or clindamycin to empiric therapy for necrotizing soft tissue infections for anti-exotoxin effects. So the ones I'm going to go into a little bit more in depth, I've highlighted or I've bolded here. I'm going to start with empiric coverage of gram-negative pathogens. So when should we consider empiric gram-negative double coverage? And there's a few instances in when you can consider this, depending on what literature you look at. But one that often comes up is severe sepsis or septic shock with risk factors for multi-drug resistant gram-negatives. So this is somebody who may be presenting with a prior multi-drug resistant gram-negative infection or colonization. So think Pseudomonas, ESBL, CRE within the past 6 to 12 months. If someone has had a recent broad spectrum antibiotic exposure within the past 90 days, if they've had a prolonged hospitalization or ICU stay, and then they develop a hospital onset infection, or are readmitted after a prolonged hospitalization or ICU stay with an infectious complication. If you do have known local unit or hospital antibiograms with high resistance rates, so say for instance, your facility has Pseudomonas susceptibility to a single agent that's less than, the literature says 80 to 90%. I think in clinical practice, most of us say 80%. So say for instance, your hospital is its gram-negative workhorse is cefepime, but your pseudomonal susceptibility rates are 60% to cefepime. That's when you might want to consider double coverage up front for your very severely ill and very severely sick patients to ensure that you're having adequate coverage up front for those patients. Other things, this really has to do with pneumonia, and we'll talk a little bit about that, but patients presenting that have a history of structural lung disease with prior Pseudomonas infections or isolates, and then neutropenic fever in very high-risk patients. So the purpose of empiric gram-negative double coverage in these settings is so you can increase your likelihood that you're going to have an active agent against the gram-negative the patient may grow. So this is when you don't know what pathogen you're treating, or maybe you know the pathogen, but not the susceptibilities yet, and you have someone who is severely ill, and you just want to increase your likelihood of having an active agent on board for them. So often in these cases, we'll pair an anti-pseudomonal beta-lactam with a fluoroquinolone or an aminoglycoside, or if you have patients that have history of carbapenem-resistant Enterobacterales, you may pair that. You may do a broad spectrum, let's say ceftazidime avibactam with a fluoroquinolone or an aminoglycoside additional agent. So in these cases, you're using two agents that have complete activity against gram-negatives, but with different mechanisms of action to hopefully increase the likelihood that you're giving adequate empiric coverage. Kind of the same thing with a suspected or documented Pseudomonas in a hemodynamically unstable patient. Once again, you're just increasing the odds that at least one agent is active while you're waiting on susceptibilities that may be pending. And it's really all about empiric adequacy. And then if you look at the most recent IDSA ATS HAP-VAP guidelines, they support empiric double coverage in your healthcare or hospital-associated, hospital-acquired ventilator-associated pneumonias with MDR risk factors. So local presence of gram-negative resistance, they have that threshold of greater than 10% resistance to the agent being considered as monotherapy. And then if a patient has risk factors for multi-drug resistant pathogens, so structural lung disease, prior IV antibiotics, or septic shock at the time of VAP. The other time where you would consider dual therapy for the folder, so let me back up a second. For these cases, we're doing empiric therapy with dual gram-negative antibiotics. But once we have the pathogens and susceptibilities for our common gram-negative pathogens, even including Pseudomonas, we can peel off that second agent and just use a monotherapy agent. Sometimes we may use dual therapy for the full duration of therapy in very uncommon pathogens. So a few of these, Stenotrophomonas, Elizabeth Kingia, there's a bunch of other ones, but some of these you may are like, I've never seen this before, and that's quite okay because these are very uncommon. But something we see more common in this list is Stenotrophomonas, and I often see this being managed inappropriately with antibiotic therapy. So I did want to go over the most recent Infectious Diseases Society guidance on the treatment of Stenotrophomonas. And they do state that monotherapy may be okay with an agent like Ceftriaxone. This is a very expensive antibiotic, though, and not every hospital may carry this. And of course, it's IV only. So this isn't a therapy option for many of our outpatients, particularly those that don't require hospitalization or may not have the social abilities to have IV antibiotics at home. So if you can't utilize that therapy, dual therapy is recommended with two of the following to reduce the risk of development of resistance on therapy and possible improved outcomes. So you would combine two of the agents listed below. So Bactrim, Aztreonam, Avibactam, that's a newer antibiotic combination as well. That's also quite expensive and not on many hospital formularies, but is an option. And then minocycline and levofloxacin. Something I see often is levofloxacin being used for monotherapy. And this is one that has been associated with increased risk of treatment failure and development of resistance on therapy. So this is if you're using levofloxacin as part of your regimen for a Stenotrophomonas infection, it's very important to continue dual therapy for the full treatment course. So moving into adjunctive antibiotics. So rifampin we're often using in traditional gram-positive infections, MRSA, MSSA, for its biofilm activity. So rifampin has the unique ability to penetrate biofilms very well. This is a AI generated image. I will give full credit to that, but it does penetrate through the biofilm and it actually helps bring in your mainstay of therapy. So if you're using it in conjunction with vancomycin, daptomycin, sometimes maybe even linezolid, it can help bring the other antibiotic into the biofilm. And rifampin itself is active against dormant or slow growing bacteria within the biofilm. And it really helps break that up. So that's what we're using rifampin for in these situations, is to be active against the biofilm and help bring in the primary antibiotic therapy to help kill the bacteria that's within the biofilm. And then last but not least, we have adjunctive antitoxin therapy. And this is for our necrotizing soft tissue infections, formerly called neck fash or necrotizing fasciitis. And this is an infection of necrosis of the muscle and fascia, or muscle fascia and the subcutaneous tissue. It can be caused by various organisms. Most commonly, though, we see this being caused by strep pyogenes or group A strep. And that's one of the pathogens that can produce this exotoxin. So this can produce severe systemic complications. And historically, clindamycin has been used as the adjunctive agent to prevent this exotoxin production. However, recently, linezolid has really been advocated to replace clindamycin in this setting for many reasons. One of these is due to the high rates of group A strep clindamycin resistance that is prevalent across the country. Just to share with you all, over 60% of our isolates at WVU Medicine are resistant to clindamycin, and there's really questionable efficacy if the clindamycin will still have the exotoxin effects if the strep is resistant to it. But linezolid retains excellent activity against group A strep and is active against those exotoxin productions. In addition, linezolid offers a better MRSA and MSSA coverage. So not only do you get that exotoxin effect or the anti-exotoxin effect, but you also get reliable coverage of other gram-positive pathogens that may be present in our necrotizing skin and soft tissue infections like Staph aureus. These can often be polymicrobial too. So our empiric therapy recommendations that we have here at WV Medicine are linezolid plus Zosyn or linezolid plus cefepime flagyl to have adequate broad gram-negative and gram-positive coverage, but also getting that anti-exotoxin effect. Additionally, linezolid has less side effects associated with it in terms of reduced risk of C. diff compared to clindamycin. So not only are we getting better efficacy, but we're reducing the rates of C. diff as well. And that wraps up my didactic portion of combination antibiotic therapy. That's kind of a crash course, but just some instances in when combination therapy may be needed, and going through the definitions of synergy, dual therapy, and then adjunctive therapy. Happy to take any questions that anyone may have.